I am a doctor based in Guangzhou. This is a story of one of my patients, 33 years old, presenting to me in what was initially thought of as common pneumonia. It was really scary that day. I was on the night shift. When he came, he was short of breath, and his lips seemed a bit cyanotic. With haste, I asked the nurse to arrange him into emergency care. Several nurses quickly took his ECG recordings and measured his blood pressure. Blood pressure is fairly normal, but heart rate was as fast as 110 beats per minute. He told me that he had a cough for more than 10 days in a row now, and he seemed to have a fever. And as usual, I was busy with many patients, and I didn't deem this case to be at the top of my priorities. I didn't expect it to worsen tonight, and to be honest, I felt a bit suffocated from all the work that I had on that day. The nurse took his temperature, which was 38.2 degrees Celsius. Fever. The patient had cough, asthma, fever, and moist crackles heard from both lungs. All this pointed to pneumonia. And it's very likely that it's a severe case, requiring hospitalization. He was obviously frightened. He asked if his life would be in danger, and mentioned the disruptions these few days would have for his livelihood. I didn't want to make him hesitant yet, so I didn't say anything. He could have all the details once he's properly checked in at the hospital. He ended up agreeing to all the checks. Before the CT, he asked the nurse if he can go into the toilet to smoke a cigarette. When I heard it, I gave him a severe scolding for wanting to smoke after having been hospitalized for pneumonia. He was a habitual smoker. This I have noticed from the very beginning. 2 rows of stained teeth, the smell, and the index finger of the left hand, stained yellow. He also quite frankly said that he had been smoking for more than 10 years, and is currently at about 2 packs a day. Good lord, he must have started in his late teens. It's with this in mind that I became more worried about his pneumonia. I arranged for Dr. Gui and the nurse to wheel him into the CT scan room. Fortunately, the examination room was relatively close by, and the examination was conducted smoothly. The results came out: bilateral pneumonia with relatively large bilateral lesions. I expected this. The blood test came back, and the white blood cell count was a little lower than normal. Dr. Gui was very puzzled. He anticipated the white blood cell count to be through the roof. After all, it was such an obvious case of pneumonia, and pneumonia is typically a symptom of bacterial infection. When the body encounters this, the body would have an immune response, raising the white blood cell count. I pointed out that what we're seeing isn't good at all. It showed that the infection may be so serious that even the immune system is being suppressed. I've seen patients progress so far in their infection that they exhibit low white blood cell count. Typically, what follows is multiple organ failure. The antibiotics from the pharmacy came back, and the nurse administered the first dose. For such a severe case, every second counts when it comes to how early antibiotics can be administered. There was a patient before who was fine when he first presented, but the next second, his organs began failing, and I can't let this kind of tragedy happen again. Considering the high possibility that the patient has severe pneumonia, I instructed Dr. Gui, who was beside him, to ask the Department of Respiratory Medicine to have a look. It did not take long for the respiratory doctor to come down for a consultation. After evaluating the situation, he agreed with our diagnosis of lung infection. Originally, he was supposed to be admitted to the respiratory department immediately, but because there were no beds for the time being, we had to let the patient stay in the emergency department for that night. For safety, I instructed him to stay directly in the emergency room instead of the observation room. For such an afflicted pneumonia patient, all that can be done is oxygen, strong antibiotics, replenishing fluids, and ensuring electrolyte balance. There's a tracheo intubation box always on standby. The patients were then asked to sign the informed consent form, the themselves. I originally wanted to call his family over, but he told me that he came to Guangzhou on a business trip and had no relatives here. His partner was in the same city though. If you're not married, then you have to sign it yourself. He probably understood the gravity of signing this document. The tip of his pen levitated above the page for a while, before finally falling down and writing his name in a crooked manner. After this, I told Dr. Gray to take good care of him, so I went to deal with other patients. I'll be right back if anything comes up. Not long after, Dr. Gray told me that his patient's family member came. It's his girlfriend. Soon, his girlfriend came to me to find out about the condition and asked if it was seriously ill. The young girl didn't leave a good impression on me, considering my culture and the traditional manner upon which I was raised. I felt judgmental about the many tattoos that she had on both arms. At the time, I did not consider tattooing as something that a quote-unquote upstanding person could do. I've since changed my mind on this matter, but that's all for later, so I'll stop talking about this for the time being. After learning that her boyfriend had severe pneumonia, she anxiously asked me if it was life-threatening. It was obvious that she cared a lot about the patient. And as I was just saying that it was stabilizing, the nurse hurried over and said that the patient's breathing was getting worse and that the heart rate was very rapid, reaching 130 beats per minute. This situation is getting very serious. I hurried back to the emergency room. Hey, what's the matter? Dr. Gui was sweating profusely. He discovered that the patient was preparing to go for a bathroom smoke break and firmly forbade him to do so. But he was refusing to listen and insisted on getting up. This disagreement resulted in his breathing becoming faster, and his heart rate soared even higher. I saw that the patient himself was out of breath, and his blood oxygen saturation dropped to 90%, so I quickly took a stethoscope and listened to his lungs. In his case, I'm most afraid of pneumothorax, because his double lung pneumonia is obvious, and alveoli damage is certainly not out of the question. In the event of one or both collapsed lungs, his life will be at risk. Fortunately, the sounds from both lungs were still symmetrical and normal, ruling out such a possibility. At this point, the patient returned to the bed and was in a slightly better condition. I told him to stay in bed. This situation is very, very dangerous. He must obey our doctors and not get out of bed. If you must go to the toilet, use the bedside urinal, or insert a urinary catheter. In short, you can't move around or get out of bed. At this time, I noticed a boxed lunch on his bedside table and asked if he ordered takeaway. He said he hasn't eaten much today and I was a little hungry, so he ordered something to eat. But I could barely eat 2 bites. It was too spicy and my mouth ulcers were very painful. Did the patient have mouth ulcers? I didn't hear him mention it until just now. In a hurry, I instructed Dr. Gui to get him some chlorhexidine mouthwash. Disinfecting the ulcer might cause it to heal faster. So after settling his immediate affairs, I was once again busy with other patients. But not long after, his girlfriend came to me again, saying that the patient felt imminent diarrhea and had to go to the toilet. At that time I thought he was feeling a bit better, and once again just wanted to find an excuse to smoke. So after dealing with the other patients, I ran to the emergency room, ready to scold him once again. But unexpectedly, a foul odor hit me as soon as I entered the door. The nurse told me that the patient couldn't help it and defecated the bed directly. It seemed that the patient was telling the truth. I was, and still am, ashamed of my immediate impulse to blame. My only relief was that the impulse never got a chance to leave my mouth. So, what does the situation look like? The yellow loose stool is full of water. Then the patient saw me. He said he couldn't hold back. He was a little embarrassed. How long did you have diarrhea? It's only about a month. After a few times, I bought some anti-diarrheal medicines and took them. Worked, sometimes. The nurse and his girlfriend helped change the dirty clothes and sheets. It really stinks, believe me. My nose is not very good, having been chronically afflicted by rhinitis due to allergies for more than 10 years. But there was an unmistakable aspect about the stench. Such a smell may indicate a bacterial infection. How many times a day? There are 4 or 5 times when it's bad, 1 or 2 times when it's less bad. This is the second time today. He told me that other than the diarrhea, there was nothing else. Stomach cramps is all, not severe. It's rare to have enteritis for more than 1 week. The patient has been in this situation for a month. So now, chronic diseases such as Crohn's disease and ulcerative colitis are in the realm of consideration. Enteritis. This disease can cause diarrhea, abdominal pain, and some blood in the stool. Interrupting my thoughts, the patient suddenly coughed violently, which made me vigilant again. I asked Dr. Gui, "Do you think that the patient may have intestinal tuberculosis?" Dr. Gui seemed to understand, and said that the chest CT did not suggest tuberculosis, at least not the typical manifestation of tuberculosis. I fell into deep thought. I visualized the typical imaging characteristics of tuberculosis. This patient doesn't quite fit this mold. But then again, all diseases can have atypical manifestations. If the patient really has TB and has been coughing without cover, would be considered close contacts. I put on my mask real quick. I also began to remind everyone to protect themselves and wear masks when they come into contact with patients. And leave the door of the emergency room open, let it ventilate. Then I asked the nurse to collect sputum for the patient and send him to the lab to check for bacterial markers of TB. 2 more bottles of IV fluid was allocated for the patient to replenish fluid lost due to diarrhea. Before leaving the emergency room, I still told him to get out of bed as little as possible to reduce the chance of incidents. This time he was quite cooperative, saying he was tired and had every intention to rest. But who knew within a few minutes something happened again. First, Dr. Gui came at me again, and said that the patient's girlfriend suddenly and angrily left the emergency department in a fit of rage. The nurses corroborated the situation and added that she just heard the patient answering a phone call. It seemed that another girlfriend called, and then this one just decided to leave, but not before angrily declaring herself to be no longer connected to this whole situation. The patient's condition is relatively serious. In case of admission to the ICU, having no family members present makes things much more difficult. The girlfriend is gone, so just ask him for the phone number of his immediate family. We'll contact his family directly and let him know. It's really unbelievable. The patient looks so weak, as if the wind can topple him. I didn't expect him to have a foot in 2 separate boats. What a scumbag. Don't be in such a hurry to label people. Maybe that's not the case. I quickly ended the topic. Our task is to stabilize him so that he can have a smooth trip to the respiratory department. His personal life, whatever it may be, is completely irrelevant. But it doesn't have to be irrelevant. It may very well affect us too. Who knows how many partners this kind of person may have had, or still have? We could be exposing ourselves to not only his diseases, but also that of everyone he's come into contact with. The nurse continued to complain. I feel sick just thinking about it. The nurse's words sent a chill down my spine. I stood still as if I'd been struck by lightning. All this time I've analyzed the situation left and right, and yet I've neglected one very terrible disease. I rushed into the emergency room. The patient has just hung up the phone, and he was relatively calm, as if his girlfriend's departure did not affect his mood at all. I went straight to him and asked him a question. Did you take any drugs? He was obviously intimidated by my question and said, no, that he's always just been smoking, and he had never touched any illicit substances. I carefully checked the blood vessels of his upper extremities, and there were indeed no needle marks. At least he didn't share needles. But why do I suspect this possibility? Because I've seen cases of serious infections caused by unhygienic use of drug paraphernalia. So thin, smokes, and had fever for a good half of a month, and now he has pneumonia and enteritis. Yes, I have to be suspicious. More importantly, I suspect that he has AIDS. When Dr. Gui heard my words, he was so frightened that his mouth could not be closed. The case has struck me as a little odd since the very beginning. How could he have such serious pneumonia at such a young age? Generally, the most severe pneumonia cases we see are indeed in middle-aged and elderly people, especially the elderly. The probability of severe pneumonia in young people is relatively small, unless combined with other factors that may compromise the immune system. And the CT of this pneumonia does not look the same as usual. This is interstitial pneumonia with many ground glass shadows. The oral ulcers, the unexplained chronic diarrhea, the low white blood cell count, these factors all confused me right until the nurse scolded him and implied they are sexually transmitted diseases. Then it became clear. It has to be HIV. The most common mode of HIV transmission is sexual transmission, followed by blood transmission and mother-to-child transmission. But I can't finalize my conclusion just yet. I closed the door of the emergency room and asked him in a low voice, "Have you ever had anal sex?" He didn't try to hide it. He was even a little jovial. He said that it happened a few years ago, and more than once. The dread inside my heart feels like it's approaching absolute zero. Did you wear a condom? Sometimes I wore it, sometimes I don't. I'm not always that well prepared. We're all men, you know. His words completely drove me crazy. With high-risk sexual activities plus all of these symptoms, I now have a very good reason to suspect that he has AIDS. If he really had AIDS, his pneumonia might have been pneumocystis pneumonia, a type of fungal pneumonia that only occurs in severely immunocompromised patients. Of course, up until now, everything is still my own inference. There's no hard evidence just yet. Originally, all patients who were admitted to this hospital had to be systematically tested for a specific set of diseases, including AIDS and syphilis. How unfortunate that it is not the case anymore. We had to get a blood test now, for AIDS, now. I clearly told him that I suspected AIDS. He froze for a moment, but he did not go into denial. I told all the nurses and doctors that the patient might have AIDS, so that everyone must be doubly careful when taking care of him. AIDS is a sexually transmitted and blood-borne disease. So long as you don't come into contact with his blood, you should be fine. As long as everyone wears a mask, there should be no problem in routine nursing work. Nurses in particular must be careful when giving injections to patients. A few nurses who had just given injections to my patients were shivering with fright, washing their hands obsessively, and then wearing double gloves. In fact, anyone with no broken skin on their hands will not be infected. Besides, it's only suspected that he has AIDS at this point. There's no diagnosis yet, so don't be too afraid, just yet. Even if he had AIDS, don't be too afraid. AIDS is now a chronic disease, and the disease can be cured by taking antiviral drugs in the long term. It's not a terminal disease anymore like we used to think of. So, don't panic. Having said all that, several young nurses were still quite frightened. Eventually, the senior nurse stepped forward and offered her charge to take care of the patient. She was more experienced and was confident in her own ability to not make mistakes. I just hope that he can get through this night safely, so that his condition doesn't get worse, and that he doesn't need to be intubated or put on a ventilator, and that he doesn't need more traumatic treatment. If his blood pressure is bad and he needs a lot of fluids and vasopressors, I might have to do a deep venipuncture on him. In that case, I'm exposing myself to the disease. But if he really progresses to that level, then these things are a must. I really hope at this point that my guess is wrong, and that I'm just scaring myself. Up until this point, we still haven't managed to get in touch with his family. The patient said that if something really gets dicey, he really would contact his family. Isn't everything still going alright? Well, the senior nurse drew a tube of blood from him and sent it to the laboratory to check for 4 immune system markers, including AIDS antibodies. After the blood was drawn, I saw that she also had beads of sweat on her forehead. It would be a lie to say that she's not nervous. The concept of AIDS as a terminal illness is deep-rooted in our generation. Even for us medical professionals, this outdated concept is deeply ingrained, let alone what ordinary people might feel about AIDS. In fact, colleagues in the infectious diseases department have repeatedly emphasized to us that AIDS is now a chronically manageable disease, not a terminal disease, so don't panic too much. That night, I visited the patient whenever I had free time. Fortunately, after receiving oxygen and antibiotics, his lungs were slightly better. My heart has also been hanging in the air, worrying that at any moment now, he will suddenly deteriorate. I must convince myself not to be afraid of him, or the situation. After all, the patient is in my hands, and there is no turning back. But then again, it's human nature to be apprehensive about things we lack experience in. We made it through the night. Finally, it's the next day. The director came and reported the situation. I wanted to make an immediate request for the respiratory department to provide a bed to house this patient, but the director stopped me in my tracks. Not so fast. Why don't we wait for the blood test results to come out? The director was right. If he is positive, he has to be transferred directly into an infectious diseases hospital. We cannot keep him in this hospital. And the director was right. After a busy day, I explained some precautions to the colleague who took over the shift and left work. Suddenly, in the middle of the night, I received a call from that same colleague. It seemed that he couldn't wait to tell me that was a positive result for AIDS. I couldn't go back to sleep again. That's right, this young man's blood tested positive for AIDS antibodies. After hearing about his history of high-risk sexual activities, the diagnosis was pretty much a foregone conclusion, no matter how much denial we felt. A cold sweat broke out on my back. I guessed right, but I was not happy about it at all. This time, instead of the satisfaction of correctly predicting the patient's diagnosis, it was a faint feeling of loss that was difficult to express in words. This is the first time I've ever had such close contact with an AIDS patient. Although I have seen several AIDS patients after that, this case has left the most profound impression on me. In the end, the patient was never admitted to the Department of Respiratory Medicine, but was directly transferred to the Infectious Diseases Hospital. I heard that he has had several more tests after that, and they all turned out positive. It's clear. This pneumonia was originally caused by AIDS. After a patient is infected with HIV, they will experience an asymptomatic period for a long time, which may be several years or decades, until the virus completely destroys the immune system. It's only after this point that the symptoms start to appear. For example, the lungs are infected with bacteria or fungi. The intestines are also infected, and there are also oral ulcers. In short, problems may occur anywhere in the body because the immune system is supposed to fight off these infections, which would otherwise be trivial for a healthy body to handle. Later I learned that the patient died in the infectious diseases hospital, and the cause of death was multiple organ failure. From the beginning all the way to the end, he couldn't be helped. He discovered it too late, and he started treatment too late. He also had a serious lung infection, and it was to no one's surprise that he could not be rescued. I suddenly wondered if several of his girlfriends would be infected. My colleague inquired and said that the girl with the tattoo also went for an examination, and that the result was negative. She was not infected by him. I breathed a long sigh of relief. That was really lucky. And the several nurses who cared for the patient that night also consulted our professionals, and after careful assessment, they were deemed to also not be exposed. So let's learn from this experience. If you engage in high-risk sexual activities unprotected, it will be too late to repent once you have one foot in the grave.